okay. May I start?
Yes, you can start.
Okay. In the next 10 minutes, I will talk on, does critically ill patient require immune modulation by nutrition? Immunity has a pivotal role in response to injury in the critically ill patient. Immune modulating strategies in the critically ill include pharmacological modulation and extracorporeal removal of inflammatory mediators. However, little evidence supports the efficacy of immune modulation in critically ill patients. Normal functioning of the immune system is crucial to the health. The immune response to injury is highly dynamic and has both pro and anti-inflammatory components. The aim is keeping homeodynamic regulation within the normal range as shown in green in the slide. Although immune modulation is aimed in many clinical trials, there are no markers allowing conclusions to be drawn on the modulation of immunity. Let me summarize the pathophysiology of the critically ill patients to clarify. Our immunity has two components, innate immunity and adapted immunity. When a patient receives a trauma, as an example, surgery, infection, burn, or whatever, the usual response is systemic inflammatory response or SIRS response, and this is beneficial. If SIRS response is exaggerated, it may result in early multi-system organ failure and in fulminant death of the patient. On the other hand, we have another system operating in the opposite way of that of SIRS. This is CARS, compensatory anti-inflammatory response syndrome, and there should be a balance between SIRS and CARS. If CARS is exaggerated, it will result in progressive immunosuppression and may cause indolent death of the patient. If the management of the patient was good, the patient will recover and return to homeostasis. This is uncomplicated outcome. But if SIRS is exaggerated or CARS is exaggerated, then the patient will have a complicated outcome, and this may result with the death of our patient. While some patients with severe inflammation may benefit from anti-inflammatory therapies, it's likely that these therapies should be carefully targeted. Conversely, many patients with sepsis may benefit from immune stimulation to reverse immunoparalysis. Unfortunately, we do not have immune markers, and we don't know the immune status of our patients in the scenario. In summary, immune modulation trials may be dangerous. What I conclude from pathophysiology studies is inflammation is generally a beneficial response to trauma or illness required to trigger an immune response. On the other hand, immune modulation, including lipids, has potential to be disadvantageous. What are our expectations from parenteral lipids? To meet calorie intake, to reduce the osmolarity, to reduce the risk of hyperglycemia, to enhance the bioavailability of fat-soluble vitamins, or to provide essential fatty acids. I think we all agree that these are our expectations from parenteral lipids. What about immune modulations? This is a nice clinical study performed in 42 volunteers. This is a randomized controlled trial, and these volunteers received either soybean oil or fish oil-based lipid emulsions or normal saline. Then these volunteers inhaled predefined doses of lipopolysaccharide, and bronchoalveolar lavage was performed to study TNF-alpha levels. The authors showed that leukocytes exhibited increased pro-inflammatory features after infusion of soybean emulsion. On the other hand, fish oil exhibited anti-inflammatory pattern. This study assessed the impact of olive oil and soybean oil on lymphocyte proliferation. Lymphocytes were collected from healthy volunteers, and lymphocyte proliferation was assessed with thymidine incorporation. In this in vitro study, a dose-dependent inhibition of thymidine incorporation was observed with soybean oil, whereas olive oil has no inhibitory effect. In summary, soybean oil is immunosuppressive and olive oil is immune neutral. Why fatty acids have different effects on immunity? The answer is because of their metabolites. Let me start with fish oil, omega-3 polyunsaturated fatty acids. These fatty acids are converted to eicosapentaenoic acid and docosahexaenoic acid, which have anti-inflammatory properties. On the other hand, omega-6 polyunsaturated fatty acids or soybean oil is converted to arachidonic acid metabolites, which have pro-inflammatory effects. And finally, omega-9 polyunsaturated fatty acids or olive oil is converted to eicosapentaenoic acid. And fortunately, eicosapentaenoic acid has no effect on immunity and inflammation. Dear colleagues, I would like to conclude my talk with this slide. Modulating immunity by parenteral lipids has the potential to be unfavorable depending on the condition of the patient. And immunological neutrality and preserving immune function are advantages of olive oil-based intravenous lipid emulsions. Thank you.
Well done, once again.
Good. Yeah.